cancer has set the standard by which other disciplines have been able to learn how to use abstracted data.
Knowing where your population is coming from, what zip code, what county, and then sending those services out and making sure that your facility can support those services. So do they need to hire more staff on the clinical side or purchase more equipment? That all plays into the cancer registry data that they've been collecting, and that has a wealth of information in it.
We are really building the foundation for the future. And it's not a future thing. We are rolling this out to customers right now, but the enablement of being able to continue the innovation on top of this, I think, is really what should be the exciting piece.
Every cancer case is a story, a life, a journey. And for decades, cancer registries have quietly collected those stories, shaping research, guiding treatment access, and informing public health. But how did this work become so essential, and where is it headed next? Welcome back to the Innovate Oncology podcast presented by Azure AI, where we explore the intersection of technology, data, and human expertise in the fight against cancer. Today, we're diving into the vital world of cancer registries, how they began, how they've evolved, and why they're more critical than ever in modern oncology care. Joining us for this important topic, we're thrilled to welcome 3 seasoned experts in cancer registry from our partners at Elekta. For the past 50 years, Elekta has become a leader in precision radiation therapy committed to ensuring every patient has access to the best cancer care possible. And Azure AI is proud to partner with them to enhance cancer registry operations through automation and AI-powered data management. This partnership builds on nearly a century of progress in understanding and organizing cancer data. To appreciate how far we've come and where we're going with technology in this space, let's take a look at the evolution of cancer registries and see how data has become one of oncology's most powerful tools. The story of cancer registries in the United States begins nearly a century ago. In 1926, Yale New Haven Hospital established the first hospital-based cancer registry. Less than a decade later, Connecticut launched the first population-based registry. These efforts were driven by a simple but powerful idea. To understand cancer, we must first track it.
We can understand that recording of a disease process, whether that be required by the state, like in the past, for sexually transmitted disease, yes, that's true, and there's reporting. But you know what? Cancer really, as a collection of analysis, data, etc., started in the 1600s when England had a bill of mortality. They were tracking deaths by cause.
Annette Hurlbut has nearly 50 years of experience in cancer registry and has played a key role in the development of several registry software programs still used today. She helps us understand how far this field has come.
That was followed in 1665 with John Grant, who pioneered medical statistics, and he was analyzing mortality data. And that laid the groundwork for epidemiology. In the 1700s, Sir Edmund Halley, he developed actuarial tables that we lovingly know as life tables, survival table analysis. And then we skip to 1926 when the first hospital-based cancer registry was established, and that was at Yale New Haven. A few years later, 1935, Connecticut launched the first state-level central cancer registry. And as a matter of fact, NACER as an organization met in Hartford, Connecticut in June of this year for the 80th anniversary of the first state-level central cancer registry. And I'm not really sure what then happened from 35 to 56, but in 1956, the American College of Surgeons required cancer registries for an approved cancer program. We know that brought great esteem to the facilities that had the cancer program approval.
By the 1970s, the urgency to combat cancer reached a national level. The National Cancer Act of 1971 marked a turning point, ushering in structured data collection through the SEER program. This marked the beginning of cancer data as a coordinated national effort.
In 71 to 73, just about the time, I began of an interest in healthcare, the National Cancer Act led to the creation of SEER, And that was the first national cancer registry. And then in 1992, Congress passed the Cancer Registries Amendment Act, and that established what we know as NPCR. Now, NPCR, the National Program of Cancer Registries, part of the Centers of Disease Control, developed key tools that we all use, Edits and Abstract Plus as their product. Now, keep in mind, we had other registry software vendors out there, a lot. I have a sheet of over 18 different companies that were trying to do their own software. Today, there are only 4 or 5. That's just of interest. In 1999, NPCR did release additional tools for the sake of the state registries. And then I simply bring us up to 2024 when NCRA celebrated 50 years. And, 50 years is a lot of time, critical to oncology care. And you know why? I think that brings us to another area. The primary goal of cancer registries is to provide a comprehensive and accurate record of cancer cases, treatment, and outcomes. And you notice when all this first started, we talked about mortality. Thankfully, this grew to be how we monitor cancer trends and how we plan and evaluate cancer control. Registries are very much a part of all of this. We're part of the supporting of research in public health, as well as improving patient by patient care. And cancer registries play a crucial role in the overall effort to reduce the cancer burden and improve the outcomes. And in these 48 years I've been employed, I have to say that we have cancer registries that are collecting the data, sending it to the state, sending it to the college, sending it federal, have totally been part of improving the public health outcome for those with cancer.
As the infrastructure expanded and cancer registries matured, the role of the professionals behind the data also began to evolve. What started primarily as clerical data collection would soon become essential to the clinical decision-making and strategy of cancer care. Oncology data specialists, or formerly known as cancer registrars, were historically focused on manual abstraction and reporting. But today, their work reaches far beyond data entry. They are analysts, educators, researchers, and strategic contributors to patient care and public health insight. Sandra Gamber, Registry Application Support Manager at Elekta and Oncology Data Specialist herself, shares what the various roles of an oncology data specialist can look like today.
The ODS professional can work in several different avenues, whether it's the central registry or at a hospital facility or in precision medicine or the cancer surveillance, world in general. There's a lot of avenues that an oncology data specialist is needed in. From my perspective, I work on the vendor side, which is one that I didn't mention, but also vendor support. So an oncology data specialist that I work with, they are at the hospital level, and they are collecting patient demographics, treatment information, diagnosis information, recurrence information, and following that patient for the rest of their life if they are part of an approved Cancer on Commission American College of Surgeon program. So that work is very important to build a profile of the patient. And hopefully we are catching these patients at the earlier stages of their diagnosis, which will lead to better overall survival.
Cancer has set the standard by which other disciplines have been able to learn how to use abstracted data.
Annette reflects on how the role and the data have shaped modern oncology decisions.
Cancer registries, certainly there are other registries, trauma, etc. And now we see an interest in pediatric. There's been an interest in the pediatric cancer registries, which pediatrics are different than adults in primary site to histology, etc. And this has been a real interest because we are seeing without this data, we might not otherwise see the trend there has been increase in number of pediatric cancers. And that is really scary. We actually, as ODS, before that CTRs, now ODS, we've taught the medical record folks and physicians and epidemiologists how to deliver useful information on what would otherwise be complex disease and long-term outcomes. So if we weren't doing lifetime follow-up, then they would not, research would not have survival. American Cancer Society uses the data we collect, etc. And back in the 1970s, the community cancer centers wouldn't have had the data to figure out the effectiveness of chemotherapy. Once upon a time, cancer would have been treated by surgery and then radiation. But now we know with chemo, hormone, immuno, that we truly have tons of data to show what works. And without the ODS, the folks actually collecting the data in the most efficient way possible through their software and EHR systems, we wouldn't have this data.
And as the role of the ODS evolved, so did the tools. Technology reshaped how data could be collected, validated, and used to drive research and treatment.
I can remember the day that we used mainframe data system, big room, big machine. We went to floppies, to diskettes, to CDs, to be now a time of telecommuting from home and just pushing a button and the data being sent. Milestones are in technology. Milestones are also in how we work, whether we work out of an office like we once did, and travel was required for training of anyone using any software or doing anything in cancer registry. The training and, the manuals that we've used, manuals are no longer necessary as far as printing a manual, putting it in a three-hole binder, etc. And so I'd like to just list some of the things that I've seen, not just technology, but I'd like to think that some of the software that I have worked on and others coming up beside ours, one of the first things we've done is to provide treatment data, radiation and chemo, hormone, immuno at the level of cycle, regimen, phases. We use the NSC drug number that's assigned or assign our own number so that we can keep track of what drugs specifically are being used. Now, I'd like to say that another milestone was the use of APIs and DLLs, ability to provide registrars with standard resources, which we call pick list or lookups for staging and site-specific schema, like primary site and histology. I remember the day of having to individually type those into a table, and now I can rely on the standard setters working together under NACER to provide those elements and truly are standards that all vendors use. We were able to add online help. Online help systems certainly help the registrar in not needing those big manuals on their desk and so many of them, but online help can link a registrar right into the resource at field level or application functionality level. User-defined fields have allowed for facilities and states and regional and national to use user-defined fields. And so Elekta and other companies certainly have a large number of data items. Now, those data items are not those that NACER collects or the college through NACER, but ones that individual states or facilities can use. That's another area. The export of data has grown from, as I had said, manual labor and disk, etc., now to rapid case reporting on a daily basis to the COC and to the state and federal as needed. State reporting as another opportunity. Right now, each individual state could have and would need to be supported. The registrar would need to be able to collect state-specific data items, report the case when it's first completed through edits, but also whenever a correction or an update is made, either through follow-up or through just an additional admission of the patient, then that record is resent to the state. There's file naming conventions for each state. There's criteria of which cases the states go to. This has truly evolved over the years. And I want to finish up with the telecommuting opportunity. I remember the days of dial-up modems to where we are now with the internet, how we can send that data abstract by abstract or whatever it is that we need to do. But let's not forget that we have the ability to work from home, which began even before COVID. It began for me in 1997. And so telecommuting has truly been a milestone. How can registrars work the most effectively, efficiently with the EHRs and to get the information where it needs to go?
But even with all of this progress, today's oncology data specialists are facing new challenges. From rising case volumes to workforce shortages and increasingly complex reporting requirements. Despite technological advances, oncology service lines today are navigating fragmented data systems, increasing documentation requirements, and a nationwide shortage of trained ODS professionals. These pressures make efficiency and support more important than ever. Annette explains how systemic factors, including funding and standard setting, influence the workload and sustainability of registries across the country. What are some of the biggest challenges you believe that ODS teams face in today's healthcare landscape?
Just a few, and these are important. The state registry and the requirement for data reporting would definitely impact the facilities. And so we've got to keep an eye as to the interest of the nation in cancer data. The training and staffing shortages that we see. In the old days, you could send someone out of a medical record and now health information to a registry to do a clinical. And now it's impossible, near impossible, to find training programs to allow that registrar the opportunity to become a registrar by being part of a clinical. And because of the requirements of having an ODS on staff, a number of the ODS folks have gone to work for themselves or for other companies, and we truly have a staffing shortage at the facility level because of that. There's a lot of money involved in meeting the challenges of the COC program's approval, etc. More data items. I am hearing more and more of data items being added, site-specific AJCC staging, making updates interim, a chapter at a time. There's less time available to abstract individual cases, and rapid case reporting is going to be the most important. How quickly can we get the most data to the end user, knowing that the end user will eventually get a complete case? We see that through our CRS, but I think if funding is cut, it may even cause the state to look at which facilities they want the data from. And I conclude with the fact that our standard setters do work together through NACER, but I saw the standard setters come together through NACER over the years, but I also now see a bit of a division, and NACER certainly has a handle on that. The colleges versus the SEER rules for reporting, which cases, which fields. So bottom line, registrars keep data, and we really don't like to lose it. Therefore, when you start a staging schema like collaborative stage, and over time that data is no longer collected, the registries are sitting there with a boatload of data that is no longer being used by anyone. So I think that a challenge is going to be when we start collecting new data items, how long do we collect them for what is the purpose, and when these registries could stop. Otherwise, the registry continues on a local level, continues to collect all this data, not knowing when they'll stop and not getting instruction, and spending a great deal of time on data items that no one is even interested anymore. Pediatric cancer has become the most interest to the nation, so to speak, along with the funding. But we've got to be able to collect the pediatric cancers, which are totally different than the adult cancers in the way that they behave and the treatment, etc. And that is a challenge for registries to continue to add new data with shortage of staff, meeting standards, and that's the way that goes. And I'd like to live forever as a registrar to see how this all ends up. But I think that we will continue to meet the challenges we always have in the NCRA NACE organizations, as well as at the state and local level.
And at the individual case level, these challenges can translate into longer abstraction times and greater cognitive workloads for every ODS.
One of the challenges that is becoming imminent in today's registry profession is the amount of time it takes to complete an abstract. The amount of time that it takes for a registrar to complete an abstract is increasing with the standard set of requirements that request them to collect more data. Some registries report to more than one entity, and the standards are different. Once upon a time, registrars could memorize codes, and that is no longer the case today. The oncology data specialist needs to reference the resource manuals to be certain the correct rules are implemented, and therefore it takes more time to abstract a case.
These challenges set the stage for why supportive technology is becoming essential, not as a replacement for expertise, but as an extension of it. As oncology data teams navigate growing complexity, companies like Elekta and Azra AI are stepping in with technologies designed to help. These innovations don't replace the vital human expertise behind every registry, they enhance it, easing workloads, improving accuracy, and giving experts more time to focus on what truly matters. Sandra describes how Elekta and Azra AI are working together to make that happen.
Addressing those backlogs when a registry is behind on reporting, the Azra AI and Elekta solutions work in parallel to help alleviate some of the manual workflow steps within the cancer registry workflow. So this partnership combines Azra AI's real-time patient identification and workflow automation with Elekta's cancer registry software. The combined technologies enable teams to automate cancer case finding and streamline data ingestion and increase the reporting accuracy.
Annette expands on where AI can support registries most meaningfully, from case finding to validation to workflow optimization.
Well, I could use an example. Suspense case finding, the activity of identifying cases. That is definitely one area. If we had a solid working with AI, we're able to go ahead and identify where cases are duplicated. That is one area.
These tools don't just help teams work faster, they help whole organizations make more informed decisions about the cancer care in their communities.
Knowing where your population is coming from, what zip code, what county, and then sending those services out and making sure that your facility can support those services. So do they need to hire more staff on the clinical side or purchase more equipment? That all plays into the cancer registry data that they've been collecting, and that has a wealth of information in it.
This isn't about automation replacing people. It's about empowering experts with technology that reduces burden and enhances accuracy. Here, Sandra shares how the profession continues to adapt and lead through change.
Well, we do have a national organization, the National Cancer Registrars Association, that is there guiding this technology as well. So they are behind us as our professional credentialing agency. They would not lead us astray. So I think we just need to put our best foot forward and understand that this technology, like other technology in the past, is actually going to be there to help us make our job easier, take some tasks away from us. So that way we're not doing manual data entry when possibly there is an import that could put that information into our abstract and into our cancer registry software at a faster pace. So that way we can focus on running more reports that can get patients on clinical trials faster. In the near future, concurrent abstracting will become more prevalent. So we need to speed up our abstracting time. So I think with anything the cancer registrars have done in the past is continue to adapt to change and work together as a profession to have discussions as to what's working, what's not working, and network with other cancer registrar professionals. So that way you can learn the shortcuts from people who may already be progressing faster than you are at adopting that technology.
With this foundation in place, the next phase of innovation is already underway. Looking ahead, AI has the potential to transform cancer registries over the next decade, from automated abstraction to real-time surveillance and improved pathway visibility. Sandra shares what the future may look like for the ODS professional.
I think with the introduction of AI, the cancer registrar roles are changing, but it's changing in the fact that they'll be curating that data more now than they were before and spending their time on other projects, because the data will still need to be validated to ensure that it is correct. But anything on the front end where we can save the registrar time of not having to do data entry, that is a blessing in our profession to help save time so we can do other tasks.
To understand how this vision becomes a reality, we turn to Robin Bodin, head of cancer registry at Elekta.
There's so many opportunities, and what excites me about this is that there are more opportunities to leverage that data insight. And we see that with a lot of customers leveraging that data to make more efficient environment in their clinics and really utilize it. And we want to tap into that too and build out that platform that enables that. So I think at the core, you kind of have that clear mission on the data side and the prioritization and innovation commitments. But then the other layer is what more can we do now? Because we built that foundation. So how do we become more efficient? How do we leverage that to value create?
And one of the platforms shaping that future is Registry Informatics.
Registry Informatics is our next generation cancer registry solution, which is the foundation for the future as we continue to bring new innovation. We have a variety of customers using Registry Informatics, and they have noticed time savings within their abstracting workflows and a positive user experience with our new solution. So this is exciting. Registry Informatics is also cloud-based, meaning customers have all the benefits of Elekta's cloud offering, which is built and automated on Microsoft Azure, including advanced security features, remote access, and seamless upgrades. Performing their backups, making sure their data is secure, doing those upgrades for them, creating their validation sets so that they're already set up there for them. That just takes one less item off their to-do list so they can focus on other tasks and gives them relief.
With modern solutions, registries are not just recording history, they are actively shaping the future of cancer care.
Cancer registry data can also be utilized outside of the clinic for broader cancer research. So we currently have a variety of metric users participating in our National Oncology Data Alliance, also known as NODA. NODA is a comprehensive oncology database owned by Elekta that brings together a wealth of data, including detailed tumor descriptions, treatments, survival outcomes from both outpatient and inpatient settings. And so a portion of this data is utilized for large-scale cancer research and statistical purposes as we speak. This allows our customers to contribute to groundbreaking cancer research that helps drive innovation and helps inform future prevention programs and treatments.
In addition, hospitals use their own registry data to make key strategic decisions. Sandra explains more.
Just to add, healthcare systems also use this data in a variety of ways, such as making resource decisions, which can include hiring more physicians and clinical staff. They use this to determine whether they need to purchase additional or different treatment equipment after review of their migration patterns. And they use it also to think about expanding the physical size of their cancer centers due to discovering that they have a larger footprint than they initially thought they had. There is significant value of automation and natural language processing in cancer registry. We have the potential to automate abstracting or components of that abstracting workflow. So we want to work closely with our customers to learn where their needs are and understand, what will make their workflow better.
I think from the registry informatics, I mean, we are really building the foundation for the future. And it's not a future thing. We are rolling this out to customers right now. So, but the enablement of being able to continue the innovation on top of this, I think is really what should be the exciting piece. Like jumping on this now to be ready for the future, because we will continue to innovate. We will continue to push the envelope like we've done for decades now.
I think initially there was hesitancy on what role AI would play in the registry. They were asking, is it here to replace me or is it here to help me? I'm not sure. But registrars are inquisitive by nature, and so they ask questions. Registrars have seen what AI can do in their personal lives to increase efficiencies, and so they feel better about its adoption into our profession. And registrars do quickly adapt. There are oncology data specialists who are working in registries today that decades ago actually abstracted on note cards and paper forms and then filed them in a cabinet. They mailed their data on a diskette to the central registry, and if there were any updates to that abstract, they mailed it on paper to the state as well. So they were all technology changes that at that time may have been met with some hesitancy, but looking back now, that seems like no big deal. So the cancer registry profession is built on change. We receive updates to our standards on a yearly basis, and our profession progresses due to these advancements in data collection. I don't think there's any oncology data specialists that would prefer to be using a pencil, paper, and filing cabinets to create a data report for their administration today. So our profession progresses with new technology, not only on the clinician side, introducing new ways to diagnose and treat patients, such as robotic surgeries or new drugs. And on the clinician side, they reduce clinical documentation time so they can focus on the patient instead of documenting. But also in the cancer registry, using technology that will assist us in being more efficient in capturing that data so we can focus on curating that data. So using technology, data, and AI is the new way of working. AI's output currently requires human intervention to audit for valid coding and to eliminate errors. And we need the oncology data specialist to ensure and confirm the integrity of what has been coded in the abstracts. And we will continue to use our quality assurance skills. AI is a valuable assistant to help move us along further and faster with less effort so we can focus on other tasks. So I see the oncology data specialist as being essential to review errors and still deliver quality data. Everything we do is centered around the role of the oncology data specialist because they are the owners of the workflow. Their expertise drives the success of our solutions, and we are committed to making their lives easier by designing new innovations that support their needs, streamline their work, and elevate their impact.
As we heard today, cancer registries are far more than data systems. They are a living record of patient experiences, treatments, outcomes, and discoveries. They're the foundation that allows clinicians, researchers, and health systems to learn from every case and improve care for the next person that walks through the door. From the earliest hospital-based registries to the powerful platforms and automation now taking shape, the heart of this work has always remained the same: to ensure that every patient's story is seen, understood, and used to drive progress. We want to thank our guests today, Annette Hurlbut, Sandra Gamber, and Robin Bodin, for sharing not only their expertise, but their passion for this profession. Their dedication reflects the countless oncology data specialists and registry teams across the nation who work every day behind the scenes to support patients they may never meet, and yet impact profoundly. And as we look to the future, there is so much to be hopeful for. With thoughtful technology, collaborative innovation, and continued investment in the ODS profession, we are building the future where data works smarter, workflows run smoother, and every patient is guided towards timely, equitable care. Thanks so much for joining us for this episode of the Innovate Oncology podcast presented by Azra AI. Be sure to subscribe wherever you listen and catch up on the past episodes on YouTube or wherever you get your favorite podcasts. Until next time, stay curious, stay compassionate, and keep innovating.